All right, welcome everyone. Welcome to our webinar on tools for understanding contextual factors that affect the health of diverse older adults. Our webinar today is being hosted by the National Coordinating Center of the Resource Centers for Minority Aging Research at UCLA. With funding from the NIA, the Coordinating Center at UCLA works to disseminate RCMAR processes, tools, and results to actively demonstrate the RCMAR's impact upon the health of diverse older adults in the United States. I'd like to begin our session today with two acknowledgements. First, I'd like to acknowledge that we are very much still in mourning at the Coordinating Center. The sudden death of our longstanding director, Steve Wallace, is very fresh in our minds and heavy in our hearts. This particular topic was really important to Steve, and I'm certainly very much thinking about him today as we discuss these issues. Secondly, as a land-grant institution, UCLA and the RCMAR Coordinating Center acknowledges our presence on the traditional ancestral territory of the Gabrielino Tongva peoples, and we hope you can take a minute to acknowledge the ancestral lands you are currently on. The staff at the Coordinating Center work really hard to provide you with updated information about opportunities and resources related to aging in diverse communities. So we invite you to visit our website for updates and announcements and to follow us on social media. Just a few reminders before we begin. Please note that we are using Zoom webinar for today's platform. This means that we can't hear or see you participants. So it'd be great if you could let our presenters know who's in the audience by using the chat function. Tell us your name, your institution, or your RCMAR affiliation. It'll give our presenters a chance to see who's in the audience. Also, please note that we will be using the Q&A function for you to pose your questions to our presenters, and we will be moderating those questions after each session. We have a great presentation in store for you today, and I'm sure some of you already have some questions that you'd like to ask our speakers, so let's go ahead and introduce them. So we have three amazing speakers with us this morning. First, we will be hearing from Dr. Patricia Jones, who leads the NIA's efforts in stimulating health disparities research related to aging. Super important for our audience today is that Dr. Jones is the Director of Special Populations in NIA, and she serves as the Director for the Butler Williams Scholar Program for Early Career Aging Researchers. We're also happy to have Dr. Amy Kind with us, who is one of the very few physicians in the country with PhD training in population health, with an active research laboratory in health disparities and geoanalytics. Dr. Kind is a leader in the field of social determinants of health, and she's leading the team that developed the Neighborhood Atlas, which you'll be hearing about today. And last but not least, we have our RCMAR colleague, Dr. Jennifer Ailshire, who is an associate professor of gerontology, sociology, and spatial sciences at USC here in LA. Her research focuses on identifying the origins of social disparities in health and aging and examining how differential socio-environmental exposures and experiences influence physical and cognitive health among older adults. Without further ado, welcome Dr. Jones, and let's get started.
Thank you, and thank you to the RCMAR Coordinating Center staff. I would be remiss in moving into my presentation without acknowledging Dr. Steve Wallace and his amazing contributions in supporting underrepresented scholars and advancing aging research. And it was a privilege to get to know him better as a professional, and really sorry for the loss that you all are experiencing right now, but certainly appreciate his contributions. As Lourdes mentioned, my portion of today's presentation will be focusing on the root causes of disparate health outcomes and addressing why it's important to study contextual factors in aging research. Next slide, please. One of the things that struck me as I was preparing for my remarks today was my time at UCLA in the School of Public Health as a graduate student. There were very few courses where I did not hear the name Dr. Lester Breslow. And one of the things that Dr. Breslow was known for, and as he enjoyed a very rich and successful 70-year career in public health, was looking more broadly beyond the traditional factors related to a person's genetic composition that may contribute to health. And among the things that Dr. Breslow contributed to, and there were many great contributions that he made, was establishing a lab in the late 50s in the Alameda County area looking at population health. And from that lab, their team executed a study that wound up being quite informative of looking more broadly at factors later on in the literature. And the team had identified 7 or so factors and found that for the average person, 45 years old in the study, and they recruited just shy of 7,000 participants. But among those that were 45 years old, if they practiced or adopted at least 6 of the 7 characteristics, that they would add an additional 10 to 11 years of life on as compared to their peers who may have adopted 3 or fewer of the items. And some of those were particularly focused around sleep or exercise or other factors. But from that finding, there was an opportunity to think more broadly beyond just genetics and biology and what are some of the factors that contribute to a person's health experience or outcomes. Next slide, please. And so to that point, I wanted to begin our conversation recognizing that our root causes of our health problems are broader than our own biology by looking at contextual factors and what we really mean by contextual factors. And so the definition that I've often heard or referenced is essentially these are causal factors related to health and illness that are external to the person. And I know that right now that's quite a bit of conversation around the social determinants of health, but for today's remarks, I want to just focus on multiple determinants of health, acknowledging that those determinants may be expressed both at the social and the physical domain. So next slide, please. So what are some examples of physical as compared to social? So those would be determinants of health that include a person's natural environment, physical barriers, particularly if someone has physical limitations or disability, neighborhoods, the built environment in terms of buildings and transportation, other forms of infrastructure, as compared to social determinants, which may include the availability of everyday resources a person needs to survive, a living wage, nutritious foods, various norms and attitudes that may be adopted in terms of discrimination, options available for different forms of transportation, and segregation in neighborhoods. So those are just some examples of physical as compared to social determinants of health. Next slide, please. And in looking at the role of contextual factors and how these components may influence health, Sandra Galeo's work in 2011 highlighted in particular the role of race, poverty, levels of education, and porous social support systems play in a person's health. And looking specifically at data reported from 2000, as you can see here from this slide, there were a number of cases of death reported directly associated to each of these different types of determinants of health. What was remarkable about this particular data set was that the number of heart attacks reported in the same year was just shy of 193,000, which was fewer than lower education. Next slide, please. So in terms of the contextual factors, looking more specifically at literature and the role each individual factor may play, We know from evidence that there are relationships, clear relationships between housing influencing both the physical and mental health. There are studies that have been documented looking at poor housing and the impact on respiratory infections or incidents of mental health or mental distress. We know there are randomized controlled trials that have been launched by HUD that documented, I believe this was a trial looking at 5 large cities and public housing in those 5 cities, and the participants were given vouchers to move to less impoverished neighborhoods. And those participants followed over time reported that the boys who were in the families that moved to less impoverished neighborhood significantly had significantly fewer anxious, depressive, and dependency problems as reported to boys who remained in the public housing environment. So we know that the built environment can have influence on health outcomes. Next slide, please. However, despite what we know from the literature, as I referenced, public health scientists have been studying these relationships for many, many years. We also know that these are not linear, they're complex, and they manifest at many different levels over the course of a person's life. Those determinants that I mentioned, the multiple determinants, offer us a lens in which we can consider contextual factors that may manifest in an upstream factor in terms of midstream or health behavior levels, or downstream in terms of outcomes. Next slide, please. So in terms of how I tend to think about these components, because they're complex and multi-layered and multifaceted, I think of these in terms of the 4 levels of complexity, one of which is the determinants of health. Another level is the dimensions of health in terms of how they're influencing a person's mortality, functionality, or morbidity. In terms of causal pathways, as I mentioned, the life course or over generations. And in terms of levels of influence, be it at the individual or interpersonal or community or societal levels. All of this playing out over the course of time and manifesting in terms of upstream, midstream, and downstream effects. Next slide, please. And so when we think about aging research and gleaning from lessons learned in other fields that have been studying the relationship for many decades, both chronic and infectious diseases alike, there have been studies, namely one in particular led by Impact and AARP Foundation, that show that for persons who are aging in place, social factors absolutely can influence quality of life and health events. 38% of older persons express concern about their ability to maintain their home life and manage as they age in place, with 1/3 of those who were of lower income strata being particularly concerned about food and meal preparation and food insecurity was mentioned at least 3 times more often among those who were of a lower income group in the study sample. So we know that there is a relationship between these determinants, the multiple determinants in healthy aging. And next slide, please. And at NIA, as many of you are well aware, we support the research conducted across the spectrum of activities, be they genetic, biological, or social and economic in nature. Our interests is to foster the development of research and to grow additional scientists, clinicians, and others alike, and to disseminate the information more broadly and lessons learned in aging research so that the community of scientists benefit from lessons that we are learning in our various studies that we support. Next slide, please. So in terms of our strategic directions for the next few years, we will continue to reference this document as we're thinking through what we support and continue to focus on improving the health and well-being and independence of older persons and supporting the overarching research enterprise that helps to inform the best way to do that. Next slide, please. Looking specifically at our goals around health disparities, as we're talking about contextual factors, as noted here in this goal, we are very dedicated and committed to supporting strategies and research that are aimed at improving the health status of diverse populations, looking at the diversity of older persons and developing and implementing those strategies that can improve how we go about including persons in research as well. Next slide, please. Next slide, please. So as we talk about tangible processes and tools available to meet the NIA goals around health disparities, we do have the Health Disparities Framework, which is predicated on the life course perspective or theory. And as illustrated here in this slide, as I mentioned in my earlier remarks, the multiple determinants of health manifesting downstream in a person's life takes place over many, many years. And the Health Disparities Framework as a tool acknowledges that life course event. There are events that happen both in the built environment, at the midstream level, and at the downstream level, but all of those are compounded over time. And the life course theory underscores that and recognizes that. Next slide, please. And so with the framework in particular, built on the life course theory, the priority populations include persons of racial and ethnic backgrounds, sexual and gender minority persons, and rural communities, as well as disability, persons living with disabilities. The levels of analyses are categorized by 4 major domains: behavioral, social, environmental, and biological. Next slide, please. And what's of particular importance with the framework, while we as a funder have traditionally used the framework as a means of identifying where we have our research investment and our portfolio across the 4 programmatic divisions, but also our offices and other areas that support career and training efforts. But for investigators in the aging research community, it's an important resource because this tool allows investigators to better delineate causal pathways and potentially think more broadly in terms of the specific targets that would be identified or proposed for a given intervention. It's a helpful reminder that there is the intersectionality of 4 determinants of health, or 4 domains, and all of these different levels of influence that may manifest differently over the course of a person's life. This framework, I'm sure many of you are aware, was developed in 2012 and later adapted and adopted by the National Institute on Minority Health and Health Disparities. And so you've probably seen this framework in one of 2 IC websites, but it certainly is a useful resource in terms of thinking through and conceptualizing new studies. Next slide, please. So to bring my remarks to a close, I just want to pose again the question that we started with, looking at why would researchers study the contextual factors to better understand and address disparate health outcomes. And essentially, as illustrated here, and this is a conservative estimate from the literature, that at least 50% of the factors that influence a person's health outcomes are of the social nature or physical nature. And it's important to consider the whole person, not just the biological component. Next slide, please. And as we are thinking through and proposing and collaborating together as a community focused on aging research, I just want to share a phrase that's probably commonly known in the infectious disease world. I first learned of syndemics through my work in HIV prevention research. And it's defined as 2 or more factors interacting with each other and potentially causing an additional burden on a person. This was work that I first learned of through Dr. Bobby Milstein at the CDC at the time, who's since transitioned to other career opportunities. But certainly the literature, next slide please, supports that syndemics has been explored and well documented in HIV, STD literature. There's also been research looking at older gay men in terms of the syndemics and undue burden experienced by this particular community. There have been studies looking at poverty, depression, and diabetes among low-income participants, as well as looking at health disparities. So I close by just offering the thought, recognizing that we have multiple determinants of health that are expressed through many different levels and dimensions over a person's life course. What is the impact of burden of disease over time for older minority adults who have 2 or more factors of health outcomes? Next slide, please. And so for that, I just leave a thought from Martin Luther King in terms of our thoughts around injustice, health, and inequality. And as we have been covering so far, we realize that there are many different components and levels to consider as we look at the whole person. And I will stop there. Next slide, please.
Thank you, Dr. Jones. That was a great presentation, and we already have a couple of comments and questions that have been posed by our audience. There's a question in the chat that I think you might be able to address in the chat. Because it'll probably take longer to respond than we have time for right now, but it's regarding the NIA versus the NIMHD frameworks. And so maybe you can just respond to our participant through the chat for that one. But there was a question submitted through the Q&A function that asks about political determinants of health. Do you have any thoughts about that concept?
Yes, I do. Had limited time and had to really be concerted and focused in making my remarks. I think that given all that has transpired, particularly over the last 19 months or so, we've certainly had opportunity after opportunity to think about how what we would probably call a social determinant probably also has now been politicized, race being among those, and certainly gives us another lens to look at the information and the literature available to us as we're trying to craft solutions to health problems. And so specifically, as you know, we're looking at race as a social and a political component of a person's life. What does that mean in terms of, as I mentioned, upstream factors and policies and practices that may have been longstanding, but revisited in different ways today that make it difficult for certain groups to advance and have full access and benefit completely from the health discoveries that are out there that have been funded by the taxpayer. So it's certainly to be considered.
Thank you so much. Let's go ahead and go to our next speaker. There's a question in the chat about healthy aging and defining healthy aging. So maybe our other panelists can respond to that question while our next speaker gives their presentation. So Dr. Kind, go ahead and cue up your slides.
Okay, thank you. All right, are you seeing the slides? Wonderful. I'll go ahead with my presentation, and perhaps we can get to the healthy aging question at the end. Does that sound okay? All right. Well, I just want to thank the entire RCMAR community for having me present today in this just wonderful panel. This is just such an honor. Today I have the opportunity to discuss our work on the Neighborhood Atlas, but I thought I would do so by giving you a rationale for why we developed it in the first place, why the metrics were important, why we chose what we did, and why we've moved forward in the way that we have. Sometimes stories can be powerful in this way. So let me see. There we go. I have no disclosures other than what you see here. Very indebted to the National Institutes on Aging for allowing my work to go forward. So as Dr. Jones explained in depth, and as this audience knows well, the individual social, environmental, and biological exposures from before birth and across the life course impact health. It impacts health across the spectrum. In particular, we're interested a lot in brain health, but certainly social determinants of health, as Dr. Jones mentioned, are a big part of this. And as we heard, many of these factors underpin longstanding health disparities. So we are very, very interested on our team, as I'm sure many of you are, about aligning our research whenever possible towards action. So we know so many of these factors are important. We know they influence health in profound ways. How do we align our work so that it can trigger changes and developments in human health to try to improve the health of populations? What types of treatment, what types of clinical interventions, and what types of policy interventions can we stimulate and use research as a lever by which to bring about these changes and improvements? We heard a little bit about the socioecological model from Dr. Jones, and many of you have likely seen this before. We know that individual health outcomes are influenced by cross-cutting social factors that span from the individual to the community and the policy levels. You've probably used this many times within your research. We regularly use it as a framework for research theory, but we can also leverage this for action. And when you're thinking about aligning research towards action, as we did when we developed the Atlas, this was something that we thought about very carefully. So intervention is possible at each level of the social ecological model. You can imagine interventions at the individual level, and we have multiple examples of this, different types of clinical interventions, different types of behavioral interventions, but we can also think about interventions at the policy level and think about triggering action and allocation of resources in a way that gets at some of these fundamental social determinants of health. For instance, more money for certain schools, more eligibility for certain populations that live in certain areas. Social policy and its definitions are incredibly powerful. So implementation science is a tool that we can use in helping us link research towards these different levels of action. And certainly you can see the definition here. I'm sure many of you know about implementation science and have encountered it in your research domains. So what implementation science tells us is that the research that is most apt to translate, that's most apt to result in real world change, tends to be very end user focused in its design. For instance, community-based participatory research, having the community at the table as you move forward, or considering the needs of the community or your other end users as you develop your intervention, or think about the measures that you use to influence your policy change. The research hopefully is conveyable. It needs to be valid, of course, but it also needs to be accessible and feasible. It has to be generalizable. It can't just be focused on one very narrow population, but hopefully is disseminatable to a much broader group. Ideally, it's scalable. So often in the research world, we'll start with a small area of testing, but hopefully we can expand that, and sustainable. And then in the field of implementation science, there also is this construct of targeting an intervention or some sort of leverage point at a minimum intensity needed for change. So there can be power in simplicity in this case. This isn't always the best path forward, but often it can be deceptively powerful. So just because something simple doesn't mean that it can't result in some real tangible and approachable changes across wide swaths of a population. It also can sometimes lead to easier abilities to harmonize effort and social change. So in keeping these things in mind, for the last almost 15 years, we have been very, very interested in thinking about social determinants of health and thinking about quantifying them in a very actionable way. We look to many other countries outside of the United States who have leveraged metrics of social determinants of health in order to inform the way they align resources to action, in order to think about the way they, for instance, allocate resources amongst their healthcare system, the way they pay their hospitals, the way they think about recruiting different groups into different resource opportunities, and the way they define eligibility. So who's able to access certain resources. Other countries I would put forward are farther ahead than the United States is in this element in this area. So we look to these other countries to get a sense for how exactly they would carry out this type of work. And what they tend to use, many of these other places, particularly in their health system operations, are very discrete metrics of neighborhood disadvantage or geospatial disadvantage at a very, very discrete level. These types of metrics typically involve measures of the social determinants of health at a very small geographic level. These types of metrics are powerful. They can be generalizable to an entire country, for instance, like the US. They can be privacy compliant. And as I mentioned, they have a very strong track record of policy application abroad. So we have a large literature of validated statistical and theoretical constructs that can be pulled from as we build such a metric for the United States. They're translatable, as I mentioned, so you can think about guiding outreach and targeting of resources using geospatial metrics, but they're also policy applicable. We can adjust payments by 10% for groups that are in certain areas, for instance. And yet in the US, they're underutilized. So when we were looking for opportunities to leverage this type of actionable metric for the United States, we came across the Area Deprivation Index, or the ADI. Now, the ADI was first developed by HRSA about 3 decades ago in the late 80s, and it was developed really to track mortality outcomes at the county level. The reason we chose it is that it had a very broad literature behind it, but it wasn't in alignment with some of these European indices that had been used for policy purposes for so many years. So we spent quite a bit of time validating and refining the metric to be in alignment with these European indices. We received a grant from the National Institutes of Minority Health and Health Disparities to update the metrics to more recent and relevant data sources. The old HRSA metrics had used a version of the census that no longer existed. And we, of course, had to refine these down from the county down to something called the census block group level, or what I'm going to call the neighborhood. And it's about 1,500 persons and population sensitive. So in a city, it's a very small geographic area, but in the rural areas, it's very large. And then, of course, we had NIH funding to validate this. Now, the ADI is inclusive of measures of education, employment, housing quality, and poverty. And on the maps that we provide free to the public, we use a heat map type format. And so what you're looking at here on the right-hand side of the map is Milwaukee County. Milwaukee County is one of the most disadvantaged counties with some of the greatest health disparities, not only in the state of Wisconsin, but within the whole US. And often the county level metrics would ascribe the entire county as being highly disadvantaged. But when you use a much more precise geo measure, in particular these census block groups, what you see is a profound clustering of disadvantage in inner city core Milwaukee, surrounded by a ring of some of the richest neighborhoods within the state of Wisconsin. So the county metrics do not lead often to the level of precision that we need to really start linking cells to communities and start thinking about some of the biological and other aspects of disadvantage as we move forward. Also, they end up being much more policy applicable, as you'll see in a moment. Now, when you use the ADI, there's some considerations that you need to keep in mind. And many of you have probably heard this before if you've downloaded our metrics from the Atlas. First of all, it goes without saying, but individual level socioeconomic factors are different than contextual level socioeconomic factors. As Dr. Jones said, there are individual level factors, someone's individual income, individual education, and then you have measures of context. Now, the ADI is a measure of context. These two factors are not equal, and they often act independently in terms of their ability to predict certain types of health outcomes. So sometimes we have cases in which neighborhood disadvantage, for instance, seems to carry a heavier weight in predicting certain types of health outcomes than individual characteristics. Additionally, the associations for these types of metrics are typically nonlinear. That means that at the edges of the distribution, at the most wealthy neighborhoods or the most disadvantaged neighborhoods, you see different associations with health outcomes than you might in the middle of the spectrum. So using analytic techniques that take this nonlinearity into effect and into account are really important. And then finally, as you interpret these types of contextual metrics, you have to realize that health disparities theory must be kept at the forefront of the interpretation and of the analytic planning for use of metrics like contextual metrics like the ADI. One example for why this needs to be at the forefront is the fact that the ADI does echo patterns of structural inequity and structural racism that we see across the United States in some areas. So what you're looking at here is a map of redlining that had occurred in Philadelphia. And redlining was the systematic denial of various services by federal government agencies, local governments, or the private sector that ultimately disadvantaged poor and minority communities. So these legacies echo, as many of you know, and they echo through to today. And we continue to have structural inequities and systematic racism, as you know. But contextual metrics like the ADI do reflect these elements, and so that really needs to be taken into account when they're used in a research forum. So as I said, our group, and certainly I in particular, am very, very keen on as much as our research as possible as being oriented towards action. And what we found is as we develop these ADI metrics with our funding from NIMHD and NIA, we were getting lots and lots of requests to share the data, to weigh in on certain policy matters, to think about how social determinants of health could be leveraged for action in a whole host of ways. And it quickly became clear to us that we needed to build a community around this area or expand the community that had access to these data. So we really embraced open science and data democratization. Now, many of you have heard of this construct before, but just so we're all on the same page, open science is the movement to make scientific research and its dissemination accessible to all. And data democratization makes it accessible to all people, not just researchers and academics, but anyone within a society. Because so many of these other people within our society outside of the research community are the ones that are either experiencing the disparities or they're the ones that are acting to make things change. Our policymakers, our community leaders, our people on the ground level in all corners of the country that may not even have access to an academic facility or a researcher who knows how to do geospatial analytics. We wanted all of these individuals to be able to access these data. And so you can see some examples of data democratization tools, both from a national level and a local level. The tool that we developed that I'll talk about a little bit more here quickly was the Neighborhood Atlas. So hopefully many of you have seen this. The Atlas allows for free customized mapping in a heat map-based format for all of these ADI metrics for anywhere within the United States. You can zoom in to any city, any state, any county, and really see more about where the most disadvantaged areas are on the basis of this ADI. It's completely free. We make the data, all 69 million data points, free for download. And we cross-link, just because not everybody has a geoanalyst available to them to do geocoding, we cross-link all this data with 9-digit zip codes. Most of our partners, particularly our non-academic partners, have access to a 9-digit zip code and can use that to link their data. Over half, probably closer to 75% of our users are not academic that have been using the Neighborhood Atlas, which is really, really exciting. We've had over 250,000 views, and to date, it's been used in a whole host of ways. So these metrics, how might they be used for research? So this is just some quick examples of metrics by leveraging these kinds of metrics and then applying them to research that can hopefully quickly become more harmonizable more quickly. So I do a lot of work in Alzheimer's disease. I'm an Alzheimer's doc, and so we were interested in brain health effects of the dosage and timing of living in a disadvantaged neighborhood across the life course. And we started by looking at these questions cross-sectionally. And what you're seeing is for a paper that was published in JAMA Neurology, in which we found that brain volume sizes differed between individuals who are living in most disadvantaged contexts as compared to those in the least disadvantaged. And this was true for both hippocampal volume and total brain volume. We saw these findings echo through in neuropathology, so these metrics can be powerful. You can start appending them to existing tissue samples using, if you can have access to information around address, and that's exactly what we did here. These were decedents who had donated their brains to the University of California, San Diego, or the University of Wisconsin, and almost all of these samples were not characterized from a social aspect, but we could start adding on additional information using some of these geocoding techniques. And indeed, at least in this very early sample, found that the odds of AD neuropathology was higher. But the power here is that many, many others can take these data and run with them as well. There's so much more that can be done than our group alone could ever do. So bringing together a wonderful community that can embrace these open data and carry them forward in a whole host of ways. But these data can also be used simultaneously to trigger real world change. And this is one area that really excites me. I'm so very pleased to say that Atlas data are currently being used for COVID vaccine allocation in at least 5 states that I know of across the country. So this idea that disadvantaged areas are more apt to be able to get these resources is just truly wonderful. And it makes the research that we do, I think, all that much more quickly actionable. The state of Maryland we work very closely with them. They use these metrics in thinking about how they carry forward their health policy. CMS under the Obama administration had started to use these, and multiple other health systems. With this work, we also, with funding from the National Institutes on Aging, will be launching something called the Neighborhood Study. Just one slide here on this. You'll be hearing more about it, hopefully in other talks in the future. But this will allow us to look at dosage and timing of neighborhood disadvantage exposure across the life course in 22 Alzheimer's disease research centers across the country for brain bank decedents and for clinical core participants. So this will result in a really wonderful data repository that hopefully many of you can leverage if you have interest in thinking about these contextual factors and how they influence brain health. So I'll just end with some closing thoughts. I hope you all are excited to embrace some of these implementation science principles. You all know that social factors are complex, but certainly anytime you apply these contextual metrics, be sure to keep health disparities theory at your forefront. And then please do embrace open science and data democratization anytime you can, because it certainly is a path towards increased real world solution. So I'll stop there. I know I've ran a bit long. Thank you.
Thank you, Dr. Kind. Just in the interest of time, we're going to go ahead and let Dr. Ailshire give her presentation, and I'm going to post some of the questions that were submitted through the Q&A in the chat, and maybe you can respond through that feature.
Yes, thank you.
Thank you.
Can you hear me okay?
Yes, go ahead.
Okay, sorry. It would be terrible if I just started talking and no one could hear what I was saying. Hi, so I'm Jennifer Ailshire. I work with the USC AD RICMAR, and I actually have a pretty short presentation. There are a lot of slides that you'll all have access to that has a lot of information in it, but I'm going to go through all of this like fairly quickly, and then hopefully that way you'll have more time at the end to ask some of your questions, get answers. But just by way of a little bit of setup or background on how I think about contextual factors in determining health and disparities. You know, we know that context is one of the key social determinants of health. If you look at this little diagram from the CDC, you see that They mention that neighborhood and built environment are one of the social determinants of health, but I actually think of it as really all-encompassing, because where people live can also determine their healthcare and quality. It can determine their social and community relationships. It is very important for their economic well-being, and it can even determine educational access, quality, and opportunities throughout the life course. So I talk about social and physical environments, but maybe it's because I'm a sociologist. I actually think that all parts of the environment are social determinants. And it's because even when I think about physical and built characteristics, like I do a lot of research on air pollution, it is a physical environmental property. But for me, it's totally socially determined, because a lot of the environmental characteristics that people are exposed to were developed over time and are reimagined within the context of relationships of power, culture, history, demographics. So for me, all environment is social. So we know that racial and ethnic minorities and people with fewer socioeconomic resources tend to live in places that are unsafe and hazardous to their health, and also that lack amenities and resources that promote and support healthy living. So what I think of as a very socially constructed situation in which people live obviously has really profound impacts on their health and well-being throughout the life course, and of course on their aging. So as you heard, the NIA Health Disparities research framework highlights the environment as one of the key levels related to disparities research. I'm going to argue today that it's one of the levels that has received relatively less attention. So despite its importance and the fact that it can really link that, the political factors determining health to the social, cultural, behavioral, and biological factors, it's kind of sort of a drop in the bucket compared to the other research that's been conducted in the past decades on aging. And as you just heard from Dr. Kind's presentation, it's largely a matter of this idea of democratization of data and open access to data. This kind of research has been particularly difficult to accomplish, but I'm going to try to convince you in the next several minutes that we're at a moment where all of you can now take advantage of all of these great resources that you have at your fingertips. So I'm just going to kind of talk about what's available, how easy it is to use some of the contextual data, and I'm going to focus on a lot of the contextual data that I've worked to develop over the past 10 years. But I will say, we make do with what's available, but as you just saw in this former presentation, it's an increasingly rich set of information. But as she also kind of communicated, there's still kind of limited research. And so the work that Dr. Kind and her colleagues are doing is really important for improving access and accessibility to these kinds of data. So I'm just going to talk about some of the data sources that I've been working with to develop contextual data. The first is the Health and Retirement Study, which is one of our hallmark studies of aging. A lot of people work with this data source, particularly at the national level. But I developed a contextual data resource that's been appended to the HRS, because when I started out as a junior scholar, I was recently told I'm no longer an emerging scholar or a junior scholar. I don't know what that makes me now. But when I was first starting out, I saw a need to have easily accessible and ready data, because when you're a junior scholar, you don't have big research teams and you don't have the big R1s that can fund this kind of thing. And so I kind of had a vision to do a little bit of this work for the research community. Of course, I needed the data for myself as well, but again, I was kind of hoping to sort of democratize that process, at least for researchers. So I built a set of contextual data resources. It's called the HRS CDR. It's what I consider more kind of user-friendly data sets. That ideally will enable researchers to engage more in this research and studying the impact of place on health and well-being among older adults. I put some links in here. It is considered a restricted data product, so it can only be accessed through a virtual data enclave that MICTA, one of the NIA-funded P30 centers, manages at the University of Michigan. So it's a compilation of data sets that contain a lot of different kinds of contextual measures spanning a lot of different domains. We have complete documentation to help people use it, and you can go on the website and you can download the documentation to see what variables are available before you ever apply for access to the data. And these are, you can merge them with the HRS geographic identifiers. So it was important to me to have data sets available at multiple geographic levels because I can't predict what people might be interested in. More of my research is conducted at the census tract level, block group level, more of the local level. But we also have information at the county level, hospital service area, and other kinds of geographic levels. We also work with staff at the Health and Retirement Study at Michigan to create buffer and distance-based measures based on the geographic location of households. And we have temporal coverage that basically spans all of the period of the Health and Retirement Study up to 2016, and we're about to start updating with 2017 data as well. So this is just a quick table. I'm not going to go through it. You can kind of peruse it at your leisure when you get the PDFs of these presentations. But this is just to show some of the different data sets that are currently available through the HRS website. You can find the same information on their website, and it's just to show kind of the sort of differences in availability by geographic level, which is largely dependent on the kind of data that are contained in the data sets. So just as an example, these are two maps of tract level concentrations of fine particulate matter air pollution. This is something that I study in my research on cognitive functioning over the life course and onset and incidence of dementia. And it's just kind of showing some of the mapping that someone could do with these data. Unlike the neighborhood atlas, we only provide the data, so you do actually have to have someone who can make these maps for you. But in the coming years, we're going to start providing webinars for scripts in R and Stata so that people can see how easy it is kind of to make these maps. And actually, you can make decent maps in Excel these days too. So I think mapping is going to be more at our fingertips than it was previously. I just want to show you one graphic that I think is relevant for our interests as researchers of health disparities, which is some work that I did with a graduate student. Actually, we did this with Karen Lincoln, who was affiliated with our USC AD RICMAR and also with the MUCWAR, so we're keeping it in the RICMAR family. But we wanted to look at the percent of older adults in the health and retirement study that live in what the EPA considers high pollution environments, high pollution for fine particulate matter. And we looked at it by race, ethnicity, and also household income. And we found this just kind of really stunning, but perhaps not surprising, that even when we looked at the highest income, older Black adults lived, about as many older Black adults lived in high pollution environments as the lowest income of white adults. So I think that really underscores the fact that people live in different neighborhoods, and it's very much patterned by historical practices that have aligned along race ethnic fault lines and socioeconomic inequality fault lines. And so for me, I really see a tremendous amount of inequality in where people live. And it's never a surprise to me then that we have these really persistent health inequalities that we haven't quite been able to tackle with individual level solutions and even with policies that don't focus on improving the living environments of people across the United States. So this is published in a nice publication that Karen Lincoln put together, and it's available on our website as well. I've also recently started appending the data to the Understanding America study. I'm telling you this for two reasons. One, because the UAS is a study of adults 18 and over, so it provides an opportunity for some of that life course dimension that Dr. Jones mentioned earlier. And two, the UAS has a large sample of people in Los Angeles, which means that they have a nice sample of Latinos, which we don't always have great samples of minoritized populations in our studies. So I think the UAS is another great resource for that. So I've just started working with them. We're starting to get some data over to them. Their data access policies are done in-house, so you would have to get in touch with the UAS to get access to the data. But this is just another summary table of some of the data products that are currently available, things like census data, weather data, food environment data, and I think they also have pollution data now. This is data in process, walkability. We're appending information on nursing homes and housing market data from Zillow, for instance. And then finally, I'm going to wrap this up really quickly just by letting you know of a couple of other data sources that are available out there. So I work with the Contextual Data Resource through one of these NIA-funded P30 centers. This is a center on population and Center on Biodemography and Population Health. So you can go to this website and you can find out much more detail about all of the data that I just blew past. But basically, you can take contextual data like this is food accessibility data at the county level, and you can link it to respondent data. You can take census tract poverty data like I did here, link it to HRS respondents, and show really large differentials by race, ethnicity, and income. I also want to draw your attention to a data set, a data repository at ICPSR called NANDA. It's the this is a National Neighborhood Data Archive. So it's that ICPSR model where you click, and then download some data and you have it on your computer ready to go. It's a kind of a different way of accessing data. You need to then be able to link it to your own respondent level data. And then finally, I'm the a co-PI of another NIA funded network where we've created these searchable tools. So sometimes the issue is you just don't know what all the data are that are out there that are available. So we have this like fully searchable page on our website where you can look by level of geography, you can look at state level data, tract level data, you can put in keyword searches. And we also provide links to some of these tools and infographics that are really important because it's one thing to have geographic data, but as Dr. Kind explained, you need an entire kind of apparatus to support looking at that data even, let alone analyzing it. And so I'll just end with two observations: that we need contextual data to understand where people live, and that this is really key to understanding potential sources of disparities and implications for policy, programming, intervention. And I also want to make it clear, the data really are increasingly available and much more user-friendly than they used to be even 10 years ago. And that RCMAR scientists have an entire network at their fingertips. So you can really get access to a number of contextual data resources, probably beyond what I've even shown you here today. And I just want to acknowledge it takes a huge team of people to put this kind of data together. And I've been very fortunate to have a lot of support from NIA over the years to make these data products available to the user community.
Thank you so much for these wonderful presentations, and I love the questions that are coming in through the Q&A function. So Dr. Ailshire, I think there are a couple questions in there for you. If maybe you could take those and submit written responses to our participants, that would be great. There was a question that came in through the Q&A function that I think is really relevant for our audience today, and it's about current trainees or our current scientists who might not be in an environment that really understands or supports their interest in looking at contextual factors in their research. So the question is, how would you recommend advocating for the importance of racial disparities research in healthcare utilization or outcomes due to structural inequities? This person has received some concerns about the fundability of such research, despite the importance of these topics. Contextual factors are commonly used in sociology, but they seem not to be as well understood in heavily biomedically focused programs. So what would your suggestions be for our trainees or scientists out there trying to get into this space, but that might be in environments that aren't super supportive of going in this direction?
That's a fantastic question, and I am so appreciative that that person had the courage to put that question out there. My first thought, I have this conversation regularly with investigators in many different settings, and I think of it in terms of team science. So I would encourage you to learn a little bit more about what the phrase team science means. I'm happy to send a link in the chat to get you going, and we'll be happy to share some articles with you offline as well. But perhaps framing the conversation in the context of team science, making the case that multidisciplinary perspectives can open resources and opportunities to think about a question from a lens that may not have been fully explored traditionally. And from that, perhaps that can be the starting point of making the case for why you want your teams to be of different disciplinary backgrounds. And I would even make the case beyond disciplines why you want to engage laypersons as equal team members in crafting research questions and going beyond the traditional role of serving on a community advisory board or a patient advisory board role, but thinking from it from a team science perspective and making the case that different lenses and different disciplinary training can open up opportunities to answer research questions using tools and processes that may not have been explored before. So I will send that to you right now.
Thank you so much. Another question that came in that I think is super relevant to our audience here today is around types of research. So the question that was posed was, how can qualitative research complement what you all have presented to us today?
I would be very happy to take a first pass at that. So we have had mixed method studies that have incorporated qualitative methods to understand what the lived experience is in these highly disadvantaged contexts. And using the metrics on the atlas and specifically using the ADI to target neighborhoods for participant recruitment into our qualitative studies. We were interested in dementia caregiving and what the experience for caregivers were like if they were living in these highly disadvantaged contexts. These happened to be African-American caregivers in Detroit that were targeted, but we also included individuals in the Milwaukee area and had a cross-national comparison in Germany, actually. And so using these types of metrics can give you a sense for the contextual areas in which individuals live and may allow for a sampling technique that allows for a specification of the question that could be important as you go forward with your qualitative studies.
Thank you so much. We're at time or over time. Thank you so much to our presenters for being with us today. This is great. Thank you, participants, for being with us this morning. I hope you found this conversation and these presentations useful. We encourage you to continue looking into these topics. We will be sending out a survey, so feel free to give us your feedback about today's presentation. We have an upcoming webinar in May, another super important topic on imposter thoughts. We have another NIH official with us and another RICMAR colleague with us, and our scientists are going to serve as panelists. So thank you so much for being with us, and we hope to see you at our next webinar. Thank you, everybody. Have a great Friday.
Thank you.
Thank you.